Welcome friends. Today we are going to learn something about mallet finger or baseball finger. Loss of the extensor mechanism at the distal interphalangeal joint leads to a mallet finger, which is also known as baseball finger or a drop finger. Mallet finger injuries are most commonly seen in young and middle-aged male patients. The most common mechanism of injury is a sudden flexion of the distal interphalangeal joint with the resistant force directed along the long axis of the finger. This leads to terminal extensor tendon tear or tendon avulsion with a bony fragment. This injury is commonly seen in baseball players or cricket players or basketball players who typically give a history of trauma to the tip of the finger while taking a catch. The diagnosis can be easily made clinically, and it is characterized by presence of a distal phalanx that rests at 45 degrees of flexion with a lack of active distal interphalangeal extension. Here is a 25-year-old male patient who was trying to catch a cricket ball when the ball hit the tip of the left index finger, followed by pain and swelling. Here we can see the typical deformity in a mallet finger, and the patient is unable to extend the distal interphalangeal joint. Here is AP and lateral views of the ring finger of the same patient, which shows no bony injury. So here the diagnosis of a soft tissue mallet finger can be made, and it can be defined as the rupture of the extensor tendon, the extensor digitorum, in zone 1. These are the extensor tendon zones of the hand, which are labeled numerically. An easy way to remember those zones is that the joints are odd numbers, like the distal interphalangeal joint being 1, the proximal interphalangeal joint being 3, the metacarpophalangeal joint being 5, and the wrist joint being 7. In mallet finger, there is a rupture of the extensor tendon, the extensor digitorum, in zone 1, that is at the level of the distal interphalangeal joint. The treatment of the soft tissue mallet finger is to put in a splint so as to keep the distal interphalangeal joint in either extension or hyperextension. There are a lot of splints available in the market, and here is a demonstration of application of the splint, keeping the distal interphalangeal joint in hyperextension or extension. And the splint is worn for 24 hours for a minimum of 6 to 8 weeks. After that, if there is a residual deformity, one has to continue with night splinting for another 2 to 6 weeks. A bony mallet finger results due to avulsion of the extensor tendon from the distal phalanx with a small fragment of bone attached to the avulsed tendon. This is an X-ray of another 24-year-old young male who had a trauma to the tip of the finger while catching a cricket ball. The lateral view of the distal interphalangeal joint shows avulsion of a bony fragment to which the extensor tendon is attached. Surgery is controversial in the management of closed acute mallet finger, but one has to do a surgical intervention in all open injuries or in injuries where there is a large bony mallet fragment with subluxation of the distal interphalangeal joint, or fractures that involve 30 to 50% of the joint surface, or It is also indicated in patients who have poor tolerance to splints. There are a lot of surgeries that can be done for a mallet finger, but the one that is most commonly done is K-wires that are put in the finger and are used as extension block wiring. It is important to treat a mallet finger because if the mallet finger is left untreated, it leads to a swan neck deformity wherein the proximal interphalangeal joint is in hyperextension and the distal interphalangeal joint is in flexion. You would find some extensor lag in your patient, which is likely with both operative as well as non-operative treatment, but it is very important to know that it does not appear to result in any sort of patient dissatisfaction or a functional deficit.